Greetings, everyone. You are viewing a recorded version of the kickoff webinar for End the Syndemic Tennessee. My name is Amber Coyne, and I am the End the Syndemic Coordinator for Tennessee. If you aren't familiar with the term syndemic, have no fear. We'll be covering that today. But in short, my role will be to facilitate a planning process to identify community priorities and strategies to create an integrated plan to address HIV, sexually transmitted infections, substance use disorder, and viral hepatitis for Tennessee. As I'm sure many of you are aware, ending the HIV epidemic plans have been sweeping across the nation. This largely started as a grassroots movement by select cities and states to create comprehensive plans to end HIV transmission in their jurisdictions, recognizing that we now have all of the tools to do so. The dark blue circles on the top map indicate where city or county level ending the HIV epidemic plans exist. The blue states are states that have created a statewide ending the HIV epidemic plan. And green states are states that are in the process of creating and ending the HIV epidemic plan for the state. You'll note for Tennessee, we have two blue dots, one in Nashville and one in Memphis, where local plans exist. And the state is green, and that's really what End the Syndemic Tennessee is. As momentum around ending the HIV epidemic planning grew, the federal government also made a commitment to end the HIV epidemic. The CDC identified 57 jurisdictions and states that typically account for more than half of all new HIV diagnoses each year. These are indicated in blue on the bottom map. They are funding these what they're calling Phase 1 jurisdictions through one grant to create ending the HIV epidemic plans if they don't already have one, and then funding the strategies in those plans through a separate grant. You'll notice for Tennessee, we have one Phase 1 jurisdiction in Memphis. When we started thinking about an ending the HIV epidemic plan for Tennessee, we kept coming back to the story of Scott County, Indiana, and their HIV and hepatitis C outbreak among people who inject drugs. Scott County is not so different from many communities in Tennessee. It's small town America with a population of roughly 24,000 people. It is a largely rural community that has been notably impacted by the opioid epidemic, unemployment, and poverty. In the 10 years preceding 2014, Scott County typically diagnosed about 1 to 2 new people a year with HIV. Between November of 2014 and October of 2015, so a little less than a year, 181 people in Scott County were newly diagnosed with HIV, and 92% of those people were also diagnosed with hepatitis C. This was a huge alarm bell for public health officials. They began to question if there were other places in the U.S. that could be the next Scott County. So they conducted a study to determine if there were counties in the U.S. vulnerable to a rapid HIV and hepatitis C transmission event. In the federal study, they identified 220 counties in the U.S. that were most vulnerable to a rapid HIV and hepatitis C transmission event. These counties are indicated in green on the top map. Tennessee is home to 41 of the 220 most vulnerable counties in the United States, so nearly a quarter. When the Tennessee Department of Health did their own vulnerability assessment to update this data and to use more local indicators, they identified even more vulnerable counties than the federal assessment. The darker the shade of blue on the bottom map, the more vulnerable that county is to this sort of event. You'll notice, though, that there are no unshaded counties in Tennessee, as every county in Tennessee is vulnerable to some degree. So when thinking about a statewide ending the HIV epidemic plan, we realize that Tennessee is uniquely positioned and that many of our counties and communities that are heavily impacted by HIV are also heavily impacted by the opioid epidemic and the viral hepatitis epidemics. Assessments like these make it clear that looking at HIV, substance use disorder, viral hepatitis, and other STIs individually will be difficult, insufficient, and ultimately unsustainable for our communities. If we want new results and lasting change, we must start thinking differently and collaboratively. And that is when we started looking at frameworks that spoke to the interconnected challenges we are facing and came across syndemic theory. So, instead of making an end the HIV epidemic plan for Tennessee, we are going to take it one step further and make an End the Syndemic plan that is explicitly inclusive of HIV, sexually transmitted infections, substance use disorder, and viral hepatitis. So, what is a syndemic? The term syndemic comes from two more commonly used words, synergy and epidemic. Synergy refers to the interaction of two or more agents that produces a combined effect greater than the sum of their separate efforts. Essentially, it's the idea that sometimes in reality, 1 plus 1 actually feels like 3 or 4 or 5. Epidemic, of course, is the widespread occurrence of an infectious disease or health condition in a community at a particular time. Together, these two terms describe a syndemic, which is two or more overlapping epidemics that are interconnected through behaviors or through biological interaction that actually fuel each other and make the overall situation worse. So we know that communities often are facing multiple epidemics at one time. So what distinguishes separate epidemics from a syndemic? Well, the original theorist Singer outlined three clear criteria for determining what epidemics are actually part of a greater syndemic. The first criteria is that there has to be co-occurring epidemics. Or in other words, the data has to say that there actually are separate epidemics. Criteria number two, the included conditions must have some sort of biological synergism. This means that the conditions must somehow interact in the body or through a shared behavior in a way that actually makes the health outcome worse. And finally, there must be common, large-scale social conditions or system-level factors that create and sustain the included epidemics. We know to truly end the HIV epidemic in Tennessee that we need to address the syndemic that HIV is a part of. After looking at the data and these criteria, we identified three other health priority areas that are part of the syndemic that includes HIV. And that is sexually transmitted infections, specifically chlamydia, gonorrhea, and syphilis, substance use disorder, and viral hepatitis. Let's walk through these criteria and discover how we arrived to this conclusion. Criteria 1 relates to data. Do we actually have co-occurring epidemics? How do we rank nationally? When it comes to the rate of new HIV diagnoses in 2017 among all people over the age of 13 in the US, Tennessee ranked 17th highest in the nation. In that same year, we had the fourth highest acute viral hepatitis B rate and the sixth highest acute viral hepatitis C rate. The data around substance use disorder is quite heavy. Tennessee has the third highest opioid prescribing rate, and it was one of the few states that had a significant increase in drug overdose rates between 2016 and 2017, with an 8.6% increase. When it comes to sexually transmitted infections, we are doing slightly better, but still have lots of room for improvement. We have the 19th highest congenital syphilis rate, the 17th highest chlamydia rate, and the 11th highest gonorrhea rate. Evidence of the syndemic in Tennessee is robust and really mirrors many of the trends that we're seeing in national data. Between 2014 and 2018, chlamydia cases in the state increased by 15%, gonorrhea by 68%, and all stages of syphilis by 47%. Significant overlap between sexually transmitted infections and HIV persist in Tennessee. During 2013 to 2018, over one-third of the reported primary and secondary syphilis cases were co-infected with HIV. And as I stated before, despite national decreases, Tennessee saw a 44% increase in drug overdose deaths from 2014 to 2018. Unfortunately, drug overdose deaths reveal just a fraction of the extent of substance use disorder in Tennessee. For every life lost to a drug overdose in 2018, 13 people were discharged from Tennessee hospitals for non-fatal drug overdoses. And as substance use continues to increase, so does the concern of that rapid HIV and hepatitis C outbreak due to injection drug use. Approximately 34% of people living with HIV that have a history of hepatitis C infection actually report injection drug use. Additionally, since 2016, Tennessee has seen approximately 20,000 new chronic hepatitis C cases reported every year. And as the distribution of these hepatitis C cases continues to shift towards younger individuals, concerns about the impact of the hepatitis C virus infection among reproductive age women and the potential to transmit the virus to their infants grows. So, yes, I think we can conclude that criteria one of a syndemic is met. Criteria two relates to biological interaction. This slide gets a little technical, and we don't need to get lost into the details and complicated mechanisms of how disease can interact on a cellular level, although I have listed these sort of mechanisms in the upper left-hand corner of this slide. The big picture here is that health conditions included in this endemic must somehow interact in our bodies in a way that worsens the health outcome or makes the body more vulnerable to acquiring another condition in this endemic. There's a ton of evidence that biologically connects HIV, STIs, viral hepatitis, and substance use disorder. For the sake of not boring you all I'm not going to list all the ways that these health conditions interact, but I will highlight some examples. Individuals with a syphilis infection are biologically more vulnerable to acquiring HIV through a number of cellular pathways, which I've listed on the slide, which actually just make it easier for the HIV virus to enter the body. Having HIV and hepatitis C at the same time more than triples the odds of liver disease, liver failure, and liver-related death. The hepatitis B virus actually escalates HIV viral replication. So, people who are living with both hepatitis B and HIV are more likely to have higher HIV viral loads, which we know is associated with poorer health outcomes. Substance use disorder has been shown in a number of studies to actually hasten HIV disease progression. So, yes, we can call criteria 2 met as well. Criteria 3 relates to common, underlying, but pervasive social forces that contribute to the epidemics. We all know that the environments in which we live, work, and play impact our lives and our ability to achieve optimal health. When we say environment, we don't just mean physical environment, but also the structures and institutions that shape our lives. These institutions include things like our healthcare system, the policy landscape of where we live, our education system, the criminal justice system, and the economy. Aspects of our environment that contribute to or sustain health disparities are what we call syndemic conditions. I've listed out some of the large scale social forces that we often hear about in the context of viral hepatitis, HIV, substance use disorder, and STIs, such as a lack of health insurance, high opioid prescription rates, racism, transphobia, viral hepatitis and HIV criminalization laws in the state, high healthcare costs, stigma, poverty, syringe service program restrictions both in practice and in policy, mass incarceration, the housing crisis across the state, rural barriers to accessing care, homophobia, and a general lack of public transportation across the state. I'm sure you can name many other syndemic conditions as well. Before we take a, a deeper dive into the framework and our process for ending this endemic, I want to highlight what we really thought was the greatest value of taking this approach and what the heart of the syndemic framework is all about. Syndemic theory is about linking cellular pathology to those larger structural forces. And in doing that, it actually shifts the blame of disease from individuals to power and inequality, which challenges organizations to move from silos to systems of care and resilience. It's about working together and addressing the health of whole people and whole communities. Syndemic theory really allows us to address the roots of sickness, which is actually inequality, while at the same time treating the symptoms, which we know as clinical care. In that way, syndemic theory challenges us to identify both proximal and structural strategies. What do I mean by proximal and structural? Let's go back to the idea of those large-scale social forces and how they actually play out in our lives. Syndemic conditions act on individuals. Individual and influence individual actions. Individual actions that relate to the syndemic include things like condom usage, getting tested for STIs regularly, using new syringes and injection equipment every time, and more. Let's say a syndemic condition of a particular community is that they have no syringe service program. Perhaps there is a policy and maybe some stigma that prevents a syringe service program from operating within that community. Well, the lack of a syringe service program might actually influence an individual action. That individual may choose to reuse or share a syringe under those conditions. But syndemic conditions don't just act on individuals, they also act on communities and create a landscape of vulnerability. Community vulnerability can look like a lot of different things, such as an elevated percentage of people without health insurance in a given community, or the number of people living below a poverty line. These are things that we saw happen in Scott County, Indiana. And it gets just a little bit more convoluted because all individuals are part of a community. And so community individual actions influence community vulnerability, and community vulnerability also influences individual actions. Remember when I talked about the injection behavior of one individual being influenced by the lack of a syringe service program? Well, if that individual shares a syringe with another person within their community, and one of them has a bloodborne pathogen such as HIV or hepatitis C, well, then sharing that syringe could result in another person in that community acquiring that health condition as well. Researchers believe that this is actually how the Scott County outbreak started. Today, majority of what we've done in public health are what we call proximal level interventions or individual level interventions. Proximal interventions are aimed at shifting individual actions, like increasing condom usage, getting tested for infectious pathogens, or using sterile syringes and injection equipment every time. In short, we're hoping to create individuals that are resilient to these overarching syndemic conditions and resilient to community vulnerability. The hope is that if you positively impact enough individuals in a community, then there is potentially a shift from a place of community vulnerability to community resilience. And while resilience is absolutely wonderful and definitely a goal, we need to recognize that this is putting all of the burden on individuals and communities to stay resilient in a healthcare system that is constantly exerting deleterious forces on it. And that is pretty exhausting. When we actually implement structural level interventions, we are actually aiming to reduce the forces that are acting on individuals and community. I want to take a moment now to talk about the federal Ending the HIV Epidemic framework, how this framework could be replicated for STI, substance use disorder, and viral hepatitis, and then how we can really challenge ourselves to move this framework just a few steps forward to encompass syndemic theory. The federal Ending the HIV Epidemic plan has 4 pillars: diagnose, treat, protect, and respond. These pillars are all supported by an HIV health force. The goals are as follows: diagnose HIV as soon as possible, treat HIV quickly and effectively among people living with HIV, protect people at risk of acquiring HIV, and respond quickly to new cases and clusters. You'll notice much of this is fairly proximally focused, meaning they are largely individual level interventions. While these strategies are effective, they may not be enough to end the HIV epidemic, as they don't explicitly address these larger structural forces at play and the interconnected epidemics of substance use disorder, viral hepatitis, and sexually transmitted infections. Now, if we were to expand the same model to viral hepatitis, other STIs, and substance use disorder, it would be more comprehensive, but still relatively proximally focused. It may look something like this: diagnose HIV, viral hepatitis, STIs, and substance use disorder efficiently, Treat conditions present and cure those with available cures, as we know some of these conditions are curable, such as hepatitis C. Protect people at risk through biomedical and behavioral interventions, including harm reduction. And respond quickly to new cases or clusters to prevent rapid transmission and comorbidity, as we saw in Scott County. Ending the syndemic takes it one step further and challenges us to envision strategies to create sustainable change for our communities by addressing those structural forces in addition to those proximal level strategies outlined in the last two slides. We believe that part of creating sustainable change and fostering a more integrated approach is shifting the way that we think about health and our language, which is why we are moving to reframe the pillar in the EHE framework from diagnose to assess. We want to commit to status neutral thinking throughout this process, which means that all people, regardless of whether they're living with a certain health condition or not, are part of the solution. Some people will be a part of the solution by getting and staying in care. Others will be a part of the solution by engaging in prevention strategies. Everyone has a place. That's why we're opting to move from diagnose to assess. Diagnose makes it unclear what role, if any, people not diagnosed play, and they can play a big role in ending this endemic. So, what would these pillars look like? Assess the social, political, and structural determinants of health contributing to syndemic vulnerability. Treat the structures, institutions, and processes that result in health inequity. Protect communities through upstream interventions to foster health enabling environments. And respond to syndemic vulnerability through sustained collaboration. We want to emphasize that aiming for structural change doesn't mean we abandon individual level interventions. This isn't a or situation, but rather a let's do this and let's also do this too. So, how do we intend to go about creating an integrated plan? Well, first off, we know what's happening in West Tennessee is vastly different than what's happening in East Tennessee for these various health areas. Therefore, the strategies and priorities are likely to be different, which is why we're proposing regional engagement outlined in this map. Over the next year, we'll be hosting community planning meetings indicated in the regions indicated on the map. These will be hosted on webinars, and when it's safe to do so, we'll move them to in-person. Overall, there'll be 5 meetings for each region. The first will be centered around setting goals and discussing the framework. Then we're going to move pillar by pillar according to the federal Ending the HIV Epidemic framework. Assess, prevent, treat, and respond. The meetings will be facilitated by a mix of local representatives as well as central office staff from the Tennessee Department of Health or the Tennessee Department of Mental Health and Substance Abuse Services. Local leadership will be comprised of tri-chairs. We'll have one health department employee, one community-based organization employee, and one community member who is an individual perhaps living with or impacted by one of these health conditions, or just particularly passionate about ending this endemic. There will also be 3 people from central office, myself, the End the Syndemic coordinator, and 2 other members of our internal working group. Together, the 6 of us will assist in facilitating conversations, answering questions, and providing data throughout these meetings. During these meetings, we'll be engaging in what I like to call the 3 essential elements of a syndemic approach. First, we'll provide data to community members illuminating the connections between these epidemics, including biological interaction, shared risk behaviors, and those social determinants of health. Once those connections are understood, then we can identify strategies to actually integrate services among these health areas, as well as create strategies at different levels, individual, community level, and system level interventions. So how will the meetings be structured? The meetings will begin by providing local data about HIV, STIs, viral hepatitis, and substance use disorder. We will present data that is relevant to that meeting topic. So say the meeting that week is about preventing, then we will provide local data about prevention of those various health conditions. Then we will present evidence-based strategies that have been used in Tennessee and other states in the US, or perhaps in other places around the world to actually address what the data is saying. From there, we'll break individuals into small groups where they'll work together to identify those proximal, community level, and structural level interventions to address the data. Then we'll reconvene as a large group. We'll share out those strategies that we identified in small groups and try to reach consensus. Ultimately, those strategies will then be placed in the End the Syndemic plan. What do we anticipate the plan will look like in the end? Well, first, we will make the case for creating an integrated plan by providing Tennessee-specific evidence of a syndemic, and make the ethical case for a framework that addresses both individual level interventions and structural changes. We will then detail the community engagement process. Who was engaged and how were they engaged? This will serve as a guide map for other jurisdictions that want to create their own End the Syndemic plan. It will also signal to all the readers of our plan how collaborative of an effort this is. Next, we envision a statewide chapter that will contain broad goals applicable to the whole state, as well as those structural level recommendations that would actually apply to the whole state as well. For example, one recommendation that may come out of these meetings is the need to update our viral hepatitis and HIV criminalization laws. Well, that is a structural change that would actually impact the entire state of Tennessee. Then there will be regional chapters. In these regional chapters, there will be regional epi profiles, an inventory of existing resources. So who are the people and the programs that exist in that area addressing these health topics? And then the strategies and recommendations that came out of those regional meetings. So what is an overall timeline for how we think this plan will come together? We really started engaging in this work in central office in December of 2019, when the End the Syndemic internal work group was formed. This work group includes the medical directors over HIV, viral hepatitis, and STIs, our HIV prevention team, the Ryan White Part B director, several folks from the viral hepatitis team, the director of the sexually transmitted infection program, folks from various programs within the Tennessee Department of Health working on substance use disorder, as well as some folks from the Tennessee Mental Health and Substance Abuse Services Department. We began meeting to refine the framework and to reach out to key internal and external stakeholders like people working in health equity, women and family health, and the overdose prevention coalitions. In March, we planned a kickoff webinar, which is what you're reviewing now. In June or July, we plan to begin those regional End the Syndemic meetings. As I mentioned before, due to COVID-19, these will be placed online. When it's safe to meet in person, we hope to do that. These regional meetings will continue until the end of the year. While this is going on, we'll be identifying gaps in information. Perhaps we have not been as successful in engaging rural voices or youth, or we don't have enough input about chlamydia. We'll then identify key informant interviews and focus groups to actually fill in those gaps and make sure that those voices and ideas are included in the plan. The draft plan is set to be released in April of 2021. Which we will then allow a 4 to 6 week public comment period where people can provide additional feedback. We then hope to incorporate that feedback and have a final plan published by July of 2021. So how can you get involved? You can register to join our regional planning group at the following link. This is how you can make your voice heard and bring your ideas to the table. The more voices we have at the table, the more successful this plan will be. So don't forget to invite your friends and your colleagues too. Together, we can end the syndemic in Tennessee. We look forward to seeing you.